Welcome to the Valor Flight Crew podcast, hosted by Echo and brought to you by Vertical Helicasts and Vertical Valor magazine. Buckle up as we take you behind the scenes of some cutting-edge advancements in emergency medicine and critical care transport. In this episode, hosts Mike Fadale and Blake Shrider sit down with Kevin Rixmann, clinical supervisor at the University of Minnesota Medical Center, to discuss a game-changing innovation in out-of-hospital cardiac arrest treatment with their mobile ECMO program. Together, they explore the evolution of eCPR and ECMO, the critical role of rapid response, and the collaborative efforts needed to identify candidates and educate community emergency services. Kevin shares key insights into the challenges of implementing this life-saving technology, from streamlining response times and improving training for EMS providers to the utilization of ECMO 99 and air medical services. We all know that caring for out-of-hospital cardiac arrest patients presents many challenges for us in the HEMS community. But be prepared to be impressed as Kevin discusses the crucial role air ambulances play in the survival of these patients. If you're passionate about emergency medicine, cutting-edge technology, and the relentless pursuit of better patient outcomes, you won't want to miss this conversation. Stay tuned as we dive into the future of pre-hospital cardiac care and the impact of ECMO on survival rates. Also, as an added bonus, make sure you check out this podcast on our YouTube channel for extra pictures and videos of the U of M's mobile ECMO program and the process behind pre-hospital cannulation. So let's get it started. Thank you to our sponsors, Metro Aviation and Precision Aviation Group.
Welcome to the Valor Flight Crew podcast, brought to you by Vertical Helicasts and Vertical Valor magazine. Produced in partnership with Echo, Every Coast Helicopter Operations, the Valor Flight Crew podcast promotes the personnel and life-saving equipment behind helicopter air ambulance services. Join hosts Mike Fadale and Blake Shrider for in-depth interviews and expert insights from air medical personnel, pilots, communication specialists, and maintenance crews who play critical roles in airborne emergency response.
Line 1 accepting.
Copy, line 1, gotcha, accepting. You're going to be talking to Rep Feather 1 on LCEMS.
All these things that you're bringing up, like it's hitting and resonating with me because these are all the things that we're implementing here at our agency and working towards that, right? And I just want people to understand, like, it's exactly what you're saying, Kevin, is like, we're not just showing up on scene, giving some shocks, running the code, and then, sheet in the street, and be like, peace, like that's turning that paradigm, right, to saying, no, like, these patients are survivable. And if there was ever an answer to that question of why are we doing all these things, why are we doing video laryngoscopy, why are we getting Lucases for all our ambulances, why are we doing all these things? For this reason, right? Because, like you said, dual sequential, good CPR, getting early recognition, like, these patients can survive. So, and I think you've really tied in, those numbers show when you can go from 10% to 30 to 40%, that's the reason why. And I think that just, man, like, Kevin, this is hitting for me, like, and I think this is really, really amazing to talk about. So as you're describing all these things, like, how does that training, or how do you correlate the training, like, not only the buy-in from the hospitals and the EMS providers, but when you talk to your team, like, can you kind of describe a little bit how you can train your team to take that handoff and run with that? Can you kind of describe kind of how that looks?
Like, as we train, like, the street, the frontline people, is that what you're asking?
Yeah. And your team, when they arrive either at bedside or a hospital, and how do you correlate, like, so you've got that buy-in now from the providers, and how can you maintain that level to where they get back to on pump and at the facility?
Yeah. So I'll talk a little bit about our rotor partnership, because I am, like, super proud of our rotor team and the partnerships that we've created. Of the EMS provider on scene has identified this patient as a probable ECMO candidate. What we do is resources, we come together. So say I'm working ECMO that day, I join the talk group. We have our helicopter that's flying out to get the patient. They join the talk group. And then we have the ambulance, maybe police on the talk group. And we're all talking, screening this patient, trying to identify when those was the last known well time, et cetera, et cetera. And then as soon as we say, okay, this patient's a go, like we're activating ECMO right now, everything is hands off, like just all full throttle, get the patient package ready to go to the helicopter, et cetera. So our average scene time, skids down to skids up for these patients, is about 5 minutes. So
Absolutely insane.
I mean, you guys know, like that's moving and grooving.
That is impressive.
For these patients. Our fastest that we've had is 4. Our longest has been 10. But at any given time, like we just say, like, what is it that matters? The only thing that matters is Jet A at that time.
Yeah.
You know, so like get the Lucas head on, that's ours. Pop our monitor on, let's go. Everything else we can do in the air. You know, we need to intubate the patient, we can do it in the air. We have good tools, we have good success. We can do it. We can shock the patient in the air. You know, you can shock the patient in the ambulance before loading them in the helicopter, and then, you know, about a minute and a half, 2 minutes later, you're airborne, you can shock them again. So just really going back and looking at with a fine tooth comb of like, what really matters in the moment and where can we shave our our minutes off. And that's where our team has really came as a collaborative effort and like understood, like, do we really need to do it that way? Do we need to bring all of these items to the back of the ambulance when we already know this is an ECMO patient? Or can we just say, like, let's just get the patient loaded and get the heck out of here? Because literally, the more time we spend, the more death we see.
Yeah.
Right. So from like the helicopter partnership, that's how we attacked it that way. And we've seen really good outcome, really good buy-in with our base out of Minneapolis. And that everyone basically does the same exact practice, which is go to the ambulance, get report, swap over to Lucas, put our monitor on, load, and get the heck out of Dodge. Transitioning to the ground ambulances, it gets a little bit more complex because, like I said earlier, is not every service is covered by the same medical director. And so what it means is like basically we have to formulate a training plan, bring it to the medical directors and say like, hey, we would like to train your staff on this process. Do you guys agree? Does your hospital system agree on this process? Sometimes yes, sometimes it's a no. If it's a no, then we kind of just have to work around the box with the medical director to see what areas they're okay with and do training that way. So it gets really complex when, you know, systems tend to get in the way and not get in the way, you know, because everyone has their own way of doing medicine.
Sure.
But, you know, hinder that of keeping consistent education. And so a couple of years ago, we had actually some confusion of medics. You know, they're like, well, we have teams wanting to do heads up CPR. We have teams wanting to do dual sequential. We have you guys wanting to do this. And sometimes when we get on scene, we just don't know what to do.
Right.
Because they're like, is it a dual sequential day? Is it an ECMO day? Is it a heads up day? You know, so we kind of
flip a coin.
Yeah. We backed off a little bit on like, okay, like we need to train only our way to like, okay, let's work with the medical directors. What are you guys comfortable with? How can we roll this education out to your team and go forth? But what we try and do every year is we try and have an educational dinner for a region. And so we just had one, I think a couple weeks ago. But basically it's our team coming in and we just present the data. We present what we've been doing, what we're seeing, and more so where we're going in the future and how we're going to partner with them.
Right.
And then it opens a table for them to be able to ask questions, raise concerns with the current process. And then we can take it back to our table and say, oh, geez, like they probably are actually right. Like this is really cumbersome for an activation. Let's rework how we activate ECMO.
Right.
And then we can bring it back to their medical director and roll it out to their team. So that's kind of a roundabout way to get to your answer, but it's really dynamic and sometimes really complex when you don't have everyone on the same exact team or the same the vision of medicine per se.
Well, if there's ever a good way to get everybody to the table, it's definitely with food.
Exactly.
Amen to that.
That's a good start.
Yeah. You know, and with food, we like everyone in EMS wants to know how did their patient do, right?
Yeah.
Like we cannulate these patients and you oftentimes don't know. So what we do is we have a follow-up. So your medical director will actually receive patient follow-up and outcome. But then what we do every other year is we have a survivor's dinner. But people who were involved in the cardiac arrest care of these patients, we invite to come to this dinner.
That's
we
awesome.
invite all cardiac arrest survivors to come. And then it's a big meet and greet revolving around food. But like that really, it's a very humbling dinner. And there's a lot of emotions in that room because
no doubt.
Like there's some patients you would have no idea that they were a cardiac arrest survivor. And it might be someone that you cannulated,
Yeah.
So it's very moving to get the EMS providers. And oftentimes, as soon as they see that, or they see the patient they brought in and know the patient is neurologically intact from being dead, they are 100% buy-in.
Well, yeah, I mean, that's how we measure all of the things that we do, all of the training, everything that we go through. Like, that's what we're looking for. That gives us that closure, and that everything we did came together, and this is the result we were seeking, and we got it. So, I mean, what better way to show that and measure that?
Absolutely.
I think it's so cool when you talk about it, the whole process for education and how much buy-in you have there. But I think of things for me in air medical and that whole mindset of, I'm trying to, one of the reasons I want to do this job is to bring more tools to the table, right? I love my toys to play with. And I think that we across the industry very much love our tools. We have the special monitors, we bring the blood with us, we have POCUS, we have, we're doing finger thoracostomies and doing chest tubes now. And like, there's all of these things that are advancing in the industry. And we're like, yes, we get to like, that's part of the resources, not just speed, is that we bring all of this clinical experience and all of these toys to be able to make a difference on the scene. And then you have this process where instead of having the complexity of that ECMO patient, because we all know that ECMO patients are super complex and there's a lot going on. There's drips everywhere, the ventilator management that goes along with it, all of the tubes and lines that are all over the place, and having to be so careful with that. And while that itself is so complex, the process to get them there, you guys have really taken it back to basics and really cut out all of the excess fluff and all of the, well, I could do this to check this, or I could do this. No, it doesn't matter. They've already had this criteria. They are an ECMO candidate. They just need to get from point A to point B. Your sole job is to cut out all of the excess fluff and get them there. And I think it's such a mindset change for a lot of air medical providers. And I think it's also, and to some extent, for some of our ground providers as well. And so that's such a cool transition. I think that's something that's where I would initially struggle with that mindset, is like, well, I could do this and I could do this and I could do this. That's not what matters. What matters is getting them to the ECMO center and getting them on pump. And that's really going to be the change in this whole process. And so it's interesting to hear how you guys have made that transition and started really, changing that mindset to move in that direction.
Yeah. And I mean, we're still always looking to optimize, but, we really leverage our clinicians to say, like, I'll talk the flight world. Like, if you have an eCPR patient or a patient going through eCPR, and you're caught up, draw gas, let's see what you're doing. Can you optimize the Lucas? Can you move it, to get a little bit more LV outflow? Could you, start an epi drip, draw gas if you have time, but at the end of the day, like, don't waste your time.
You're not saying you can't use your toys, just use them appropriately.
Right. Exactly. Because you're right. Like, we all love it, right? Like, that's why we got into the job that we're in. And even the ground providers are the same. They're the same way, like, we want to do the intubation, we want to do the IO, we want to do the IV, things like that, And so, like, absolutely, please do that, but do it at the expense of driving on the road versus the expense of time on scene.
So we kind of talked a lot about, getting these patients to the ECMO center itself, right? But there is another resource that is out there in the community, which would be ECMO 99, right? Are you able to talk a little bit about like how that integrates into this whole process and when one process is utilized versus another?
ECMO 99 is a very complex process. I always remind people, anytime our mobile team is activated, we start talking about 4 or 5 different entities being involved.
Wow.
And we all know the more fingers you have in the kitchen, the easier it is for a mistake to be had.
Yeah.
And anytime a mistake happens, like, drastic outcome to the patient is oftentimes observed. So by what I mean is, we have a 911 dispatch center who receives the 911 call. Well, first you have the bystander who calls 911. So there's one. You have the 911 dispatch center. You have the incoming PD, fire, and EMS. They have to recognize and contact our ECMO team. So that goes through another dispatch center. And then the dispatch center then contacts us. But more so, they contact the hospital we're going to. So there's number 6. And then depending on what site we're going to, we have other resources that get called in. So there's potentially 7 different people. And so that's just for an ED or a cath lab activation. So 7 people there. And now when we bring ECMO 99 in, we have a third-party contract through Edina Fire that they get involved. So, when ECMO 99 goes live, we have about 8 different teams that are actively involved in getting that truck out the door.
And everything has to go exactly according to plan.
Yeah. And in a fast-paced manner.
Yeah.
So it took us a little bit of time to figure out, like, what is the most ideal situation as to how can we get this truck out the door and things like that. So we don't have a dedicated team because obviously with COVID, staffing shortages, things like that, it's crazy how we still haven't recovered from any of that. But, the fire department serves 3 ambulances plus a full-time station. And then we're asking them to staff our truck as well. So if they're out on a full structure fire, the truck might not be able to go because they don't have any staffing available. So we had to figure out, like, how do we take the 911 or the ECMO request and figure out, is our truck available? Is it not available? So that was a learning obstacle to figure out, like, is there a quick way? Because again, every department is like of its own entity. And so we don't share CAD. We don't have cross communication, things like that. So it gets really, really complex in the Minneapolis area. But basically what we found is, like, our comm center can call their dispatch center, Edina's dispatch center, really quick and say, is 99 available? If so, yep. Okay, perfect. And then it goes back to the drawing board of time is of the essence. So where is the team at? Where is the patient at? And where is the middle location? And so sometimes it's the hospital, sometimes it's the truck, sometimes it's the university. And so the cannulating physician is the one making that decision.
Okay.
And what we really leverage on, and this kind of steps backwards in the EMS role, is, we really tried to go away from cell phone use in EMS, and we should be using the radio and things like that. But we've really asked that the EMS provider call on a cell phone, because what that allows them to do is talk directly to our cannulating physician.
Yeah.
And they can really say, okay, so you're where? Like, how long? So we have a time to transport call out. Like, how long until you're ready to transport? Because if it's 10 minutes, because you're in the back hallway of a 3rd-story building, versus if you're street level, that's going to change our driving distance. So maybe it's 15 minutes to go to the U and 10 minutes to go to Southdale, or 20 minutes to go to North. If you have a 20-minute time to transport, then we say, okay, yeah, like, we can get to you guys. It's a 5-minute trip for you to go to North versus, 20 minutes to extricate the patient out of the house, plus another 20 minutes to drive to the university. We'll be waiting there for 30 minutes before you guys arrive. So it really comes down to understanding geographical location of where the arrest happened, what the EMS provider is seeing, but then also, like, where is our team staffed? So our providers respond in a quick response vehicle, and then our team has a quick response vehicle as well, all obviously equipped with lights and sirens. So we drive to the patient, emergent, and things like that. So that's kind of how ECMO 99 works, in the fashion of, do we use it? Do we not use it? It's totally dependent on the day, the time, patient location, team location. But at the end of the day, that doesn't change whether we're talking ECMO 99 or one of our satellite sites, because we have the same activation process no matter what call.
Right. Really trying to streamline what it is and let you guys figure out what the right resource is for that patient at that time.
Thank you to our sponsor, Metro Aviation. Metro Aviation, the world's largest family-owned aeromedical operator, offers comprehensive aircraft services with 140 plus aircraft in over 25 states. The Completion Center installs medical and law enforcement kits and avionics, serving diverse aviation needs including offshore, utility, VIP, and corporate sectors.
Yeah, exactly. Yep. And like we went back to the drawing board and we figured that out. Like, how can we make it easy for the EMS provider? Like, cardiac arrest scenes are chaotic. You know, everyone's amped up. You have family,
Yeah.
PD,
There's a lot that goes
first
into
responder. And so, like, how can we make it as easy as possible to cognitively offload the medic or the EMT, that they don't have to think like, oh gosh, what cannulating site is closer? Like, just call us and we'll help you. You know, we're fresh and available because we're not on scene. So we can say, oh yeah, like this seemingly, and then you can put your, provide your input as well. It's like, well, traffic is horrendous going that way because we just came from that direction, and be like, oh, okay, let's shift and go to the university instead.
Right. So as we were further asking about times and trying to figure out to allow the EMS providers to focus on resuscitation and identifying the right patient, getting you guys involved with radio comms, right? To be like, hey, this is where we're at. It'll take us this long. When we're discussing the times, are you able to give us kind of what some of those times are, or some of those goals, like for arrest to ePCR, or the scene times for EMS or HEMS, and or that needle pump time? Can you kind of describe what those goals are?
Fast.
Thanks for clarifying.
Yeah. You know, we'd say, what's your fastest? And then shave off a couple minutes, and then that's what we want for time.
Right.
You know, but at the end of the day, we have to be safe, right? Like,
sure.
We know the faster we push people, you forget about certain safety standards. So like that has to be the priority focus, because if we save one life but we kill 3 others, it wasn't worth it.
Right.
You know, but for HEMS and ground providers, like we would love for the recognition of an eCPR candidate to be within, like we teach that you don't even have to be on scene. Like if you get a CAD update or a radio comm update saying like an AED has been shot, like a defibrillator has been activated and deployed, and a successful shock has been provided, like that's good enough right there.
Yeah.
Right. Like, you know, if you know the patient's within the age range, immediate bystander CPR, 1 failed shock, and you're not on scene yet, like we really train them to be like, okay, like this is a good candidate. Because then what they can do is they can brief the whole crew in the ambulance or in the helicopter when they're flying out, like, okay, guys, like this patient is a viable.
But it's also 3 simple criteria to remember. It's not this whole long list of inclusion or exclusion criteria. It's simplified to the process where, you know, anybody who's listening to that call intake or that information or seeing that can really get a clear idea of this is or is not a candidate.
Absolutely. And, you know, call us. And if you get on scene and the patient isn't what it was, we're happy to cancel. You know, it's just like in the flight world. We don't care. We get activated, we get airborne, we cancel. Okay, no big deal. You know, we might feel a little different at 3 a.m. with that statement, but, you know,
I have no idea what you're talking about.
You're, you know, minus 20 up there, you know. Or,
Right, yeah.
Yeah, you can keep that.
Yeah. So, you know, from the time of 911 to recognition, I don't know exactly what time that would look like, but ideally we're making decisions off of CAD data, and not decisions whether we're going for ECMO or not, but decisions of like, we think this is a good candidate. Like we should put the afterburners on and really quickly decide, is this or is this not? Right. And then if it is, your scene time should be ideally less than 10 minutes and get transporting to the ECMO center.
Right.
Yeah.
So from time of 911 to on pump, obviously we want it less than 60 minutes. On average, after we've been doing it for this many years, our average 911 to on pump is about 55 minutes.
Nice.
And that's
awesome.
just, it's complex.
Yeah.
Yeah.
You know, you have.
And that's whether the patient's coming in by ground or by air.
Yep, correct.
Wow.
Yeah. So that's the nice part about it is like we've really shown that we can use HEMS and expand outward, because the patients that we originally weren't getting because they were outside of that 60-minute window, we're still getting to an eCPR center within 60 minutes.
Yeah.
You know, and so it's really opened the door for that potential. And now we're looking at putting ourselves on the helicopter and flying out there. So this is now a new hub scope.
So that's the latest and greatest where we're going.
Yeah, exactly. And then, you know, we're probably looking at, we're going to go on scene in the metro and cannulate in the back of an ambulance. That's
Yeah.
probably where we're heading next, because we've plateaued with the time. We can't beat that. There are certain patients we can, but it's hard to beat the average of 50, 55 minutes because it's just so complex with traffic, getting patients out of the house and things like that. So that's kind of what we're looking for. But as you grow a program, like shaving, trying to optimize everything. So we went through and redesigned our bag. We custom made our bags to the fact we don't even have to open them. We just unzip the first part and it has everything we need to get the patient on pump. And so we, you go through and how can we shave this and do this? We just went through and redefined our heart pack, which is like all of our sterile equipment, to have basically everything we need in it to do the cannulation. So now we don't have to sit here and open all the, sterile items. Everything is just in our heart pack. We open that and then gown up and start going. So, over the course of years, we've really found, okay, well, this buys time, this costs time. And so now we've been able to go back and be like, well, let's try this. Because we have the experience. We know what it looks like without shaving time. And so now where can we shave time and can we see a drastic outcome?
So that brings me kind of to the next question. When you talk about the whole like shaving all of that time off, obviously this, needs to function as a well-oiled machine, right? This is not something where you can just fake it till you make it. Like you guys have got to be like on the ball from the get-go. And so you mentioned that, you have your 4 physicians, correct, that cover 24/7, 365. And then your partnership with the flight clinicians, and how many of those are there again?
So there's 13 total.
13 total there. So like, obviously there's more people that are part of this puzzle, but like, how do you train these flight clinicians to also be in the role of assisting in cannulation process and working with the 4 physicians that you have, and like making sure that all members of that team are this well-oiled machine and able to make this process as smooth as possible? And then I think the other aspect of it that kind of, when you were talking, was interesting to me is the level of humility that every single one of those providers has to have in the ability to look back at their own process and say, I can do this better. And like, I guess there's certainly there's something to be said for that, because I feel like, in this world, we're very proud and we don't like to accept that we could change the way that we're doing something because we've already done it the best that we possibly can. And so it just how that whole process works for you guys, because we talk about debriefings in the HEMS industry. Like, I'm assuming that there's probably a debriefing after every single one of these cases and practices and performances that you're going through in order to make it better for next time.
Yeah. First comment I'm going to have is I can't wait to hear feedback to some people saying, how many more times can they say time on this podcast?
It's slightly a factor, I guess.
Yeah. Because I already know that's going to happen, but that's funny. So it's unique because obviously, like when I came on the team, I was a part of the people being trained. The second and the third cohort of people that we brought on, the second team, I wasn't as involved because I was just kind of stepping into the base lead role. I wasn't the clinical supervisor at that point in time yet. And then the third cohort, I was really involved. And the third cohort had a majority of them as medics.
Yeah.
No foul to medics, but like we were training.
But it's a very different process than you're used to in anything you've done in paramedicine.
Yeah. And like we were training, it was like, okay, like put on your sterile gloves. And the one medic was like, how do I do that? I was like, oh, I guess I didn't even think about that. Like, why do paramedics have to put sterile gloves on? Maybe suctioning, but I don't think we really teach that in the paramedic program as to how to put on sterile gloves. Right. So it's like, it's just like the one-offs of like, that's an interesting thought. I never really thought about it that way. Like, how do you set up a sterile field? How do you do this sterile? How do you do that sterile? It's like not a normal practice for some providers. And to really go back to that and like fully understand like everyone's background and their history. So what our training program looks like for onboarding our clinicians, because it is a unique skill set. You're side by side, first assist,
right.
Sending dilators down, feeding wires, prepping cannulas, clamping out circuits, doing wet-to-wet connections, etc. So it's a very unique skill set.
Yeah.
But what it allows us to do is we have about, I think it's 80 hours of online lecture material that covers like the program background, why we do what we do, why we believe in what we believe in, which is fluoroscopy. We're a fluoroscopy-based team. And we solely believe that that is the best because we can physically watch the cannula go up and sit at the junction. And so we know that we're pulling everything out of the right atrium. And so our need for a second assist device, particularly one to offload the LV, isn't there. Like we don't need an impella to help with LV distension. Obviously, there's one patient population that does, but that's a whole side topic. So we have these online lectures that they do. And then we have mannequins, gel mannequins, which allow us to do the procedure. And so we have it written out in a step-by-step fashion, and we teach the clinicians, like, you need to be able to do this procedure. And so they train, like they're the ones doing the cannulation. And that's really important because we say, like, you should be one step ahead of the physician, which if you're working with Dr. Yiannopoulos or Dr. Martis, like, that's very fast to be one step ahead of them.
I can only imagine when it only takes 4 minutes to get on pump.
Yeah. But it's like, you should be having your dilator ready, or you should have this ready. And so to try and teach someone that theory, it can get complex. But at the end of the day, we have a really, really dedicated group who come in on their days off. We meet every month. We have physicians who will do training with them. So what it looked like is you do the gel mannequin training, and then we have an animal lab. You go down and help with cannulation there. We have the cath lab where you can go and assist or observe cannulation. And then we have rounding upstairs in the ICU. So we can go and round on our patients to fully understand, like, what is the complexity of ECMO? Like, what does drip management look like on ECMO?
Right.
What does lab management look like on ECMO? And in particular, this is important for people who do not have like the CV background. You know, in transport, we see these patients 30 minutes, maybe an hour. Fixed wing might be 7 hours, but at the end of the day,
it's okay, Blake. Don't worry.
Sorry, my face spoke.
Down.
Yes. At the end of the day, like, you can't teach people critical care very well in those environments, you know, versus in the ICU when you're sitting there watching your patient, looking for the one finger to lift. You know, it's really easy to hone in on critical care concepts in that fashion. So we found that if we can get people up to rounds where they're working with a physician, they can fully explain things at a different level. And then our team has to do shadow days. So we asked that they do at least one, but last year we changed it to 2. And our team was really lucky that every single person got to see at least 1 or 2 cannulations. Wow. And so they were working with an experienced provider, physician and clinician who've done the procedure multiple times, and just kind of dabble in and show them the tricks and the trades. So after every single cardiac arrest case we do a debrief. It's not a debrief where it's active, but it's the clinician and the physician can chime in. But basically what we do is we do a description of like what we had, what happened, and then what went wrong or what went well. And so basically we put the ABG results. Some people will put like fluoroscopy images, pre and post PCI, so you can see what that looks like. And then like hiccups that they had with EMS providers or comms or response times, location issues. And that allows us to all go in and read it whenever we want and actively participate in like, oh, like I also had this, I did this. And then we have like a live time group chat. So like if you have problems and you're troubleshooting a pump on site, like we're all available. You can text us or, you know, call me and we do, you know, chat over it at 2 a.m. But it is what we do. So that's kind of like what we did to train our team into like the optimization of cannulation is working side by side with a physician. And when we first start, like your training, we say anytime you're on shift, you should be up there actively doing the procedure. And, you know, we've been thankful to have the tools and resources that we can do that. so that the team can, like our clinicians can do the procedure by themselves. Now, like functionality, like doing the needle puncture on an actively ongoing cardiac arrest patient, a lot more complex. But the gel mannequin, the needle puncture is easy, and then it's all about the procedure after that. So
Right.
our clinicians are able to physically do the whole procedure by themselves.
And I think that really like helps to bring buy-in to it, right? Not just to those clinicians that are involved in the process, but now you have those clinicians who also are flight clinicians taking that back to their bases, talking through the processes, trying to work out, process flows for before the patient is getting to the hospital to optimize getting there as quickly as possible. And I think it really resonates. It's that, ripple in the water effect. And it really resonates across more than just the core team itself because of bringing them in as flight clinicians and having that experience and exposure. And I think that's something that's so cool, like to be able to see that ripple effect that's occurring for you guys.
Thank you to our sponsor, Precision Aviation Group. Mission-critical operators and fleet managers rely on Precision Aviation Group as a worldwide leading rotor and fixed-wing MRO provider. PAG provides tip-to-tail solutions in 4 MRO segments: avionics, components, engines, and manufacturing DER services. A single point of contact gives you access to over 150 million in inventory globally, 24/7. Just call 800-537-2778. Precision Aviation Group. Others sell parts. We sell support.
100%. Yeah. And I mean, like, that's the unique part about ECMO 99 is, so we go from a team resource of like in the ED or in the cath lab of like anywhere from, like cath lab's not 8, but in the ED, we have probably 8 to 10, maybe 12 people who are assisting in the resuscitation. In the back of ECMO 99, it's a clinician, a physician, and we get a fire medic. Sometimes we get 2 fire medics, but we do all the same things that we do in the ED or in the cath lab with just basically 2 people. So like the clinician and the physician are the ones doing the critical care resuscitation. Our fire paramedic is a partner for operation of the truck. So setting up like the C-arm, setting up and deploying the actual truck itself, operating the ramp, getting EMS in and out. Everything else falls on our team. So like when we talk about the truck, people are like, man, I just feel so stressed out. I'm like, it's because you are. Like you're doing literally like
you should be.
Yeah, you're bringing the patient in, you're doing the cannulation with the physician.
Yeah.
Once you're on pump, you're going over to do the intubation, mix up drips, all while managing the cardio help while the physician is doing contralateral lines. And it's just like you're moving at 1,000,000 miles an hour doing 8 different things at once. And so that's where like our team dynamic really, really plays in. Of
Sure.
Like if I'm busy intubating, Dr. Bartis might have to manage the cardio help really quick while I'm mid intubation. Or if he's busy doing venipuncture, like I might have to manage drips or manage the cardio help myself. And things like that. So we really, really leverage off of one another in this team for true patient outcome.
That's pretty awesome. And now, if I understand correctly, if you end up utilizing ECMO 99 in that process and that whole craziness that you just talked about going through for 4 people, you're not transporting in ECMO 99 then, correct? Like, is it an outside ambulance service? Are you calling in the helicopter all the time? Like, what's the actual process for getting that patient then to the appropriate center?
Yeah. So most people, like, they've seen pictures of it, but until you see it in person, like the bumper is up over my shoulder. So I'm 6'1". So the back of the ambulance is like, the truck is a beast. It's bigger than a city bus.
Wow.
And so to get it in the streets of downtown Minneapolis would be an absolute nightmare. And that's, or like, I'll show you a video, that has like what it looks like when we use ECMO 99, and it just does a walkthrough of exactly what the workflow is, and it shows the true dynamic of our truck. But yeah, you're right. We don't transport in ECMO 99. Simply 2 concepts. It's massive, and secondarily, we use fluoroscopy, so we have to have a fluoro table in our truck. And so we took out the stretcher pins, so we physically don't have a cot in there right now. We just use a fluoro table. Okay. And then we transfer them onto an EMS agency stretcher and into their ambulance. So if you look at like safety of movement of ECMO patients, it's not the ideal workflow. Like ideally, we cannulate in the truck, we lock them into the truck, and we transport them in that truck. But the realism of transporting that truck would be, whew,
Yeah. Wow. That's
someday
impressive.
maybe.
That's really cool.
When you talk about when you're cannulating, so if I understand this correctly, the ECMO 99 unit, you get to either the hospital to where you get that patient, you cannulate in ECMO 99 because you have the fluoroscopy table, you have everything. So you get the patient on pump, and then you move them out onto either the ambulance, or if they're going by helicopter, they go on that stretcher, correct?
I was going to say, so ECMO 99, we only use it as a metro resource because it's housed in Edina. And then obviously with that hub and spoke model, we can get it about 20 minutes
Okay.
outside of that ring. So we use it as just kind of, it's like a standalone pop-up shop cannulation site, if you will. That's the easiest way to understand ECMO 99 is it's a rendezvous point,
Right.
if you will. And so the truck is deployed. We ramp the patient up. We physically bring the patient up on a ramp. They roll in. We slide them over to the fluoro table. And then the 911 crew can leave. They can stay. And once we're on pump, it takes about an hour from on pump to suturing to contralateral lines to a little bit of resuscitation. So about 1 hour, we're ready for transport. And then we call in another ALS service. We can even do BLS because we go with the patient.
Because you have everything and you're just moving the patient. You just need transport.
Yeah, we have a ventilator in our truck. We have a monitor. We have pumps, meds, the cardio help. So we do all of it. Even if we have an ALS critical care truck, we send our clinician or physician with the ambulance to manage that patient. Just because like they are so sick at that point, you know, and there's a transition phase of about the first 4 hours where things might be great. They might not be great, but they all transition to the point where it's not great at all. So like aggressive resuscitation, lots of vasoactive support and things like that. So
would it be fair to say for your program going forward, could you transport, so you have that unit, right? If you're there, you said you have the fluoroscopy table, like what could that future hold? Or could you, so instead of having to remove that patient, put them in another unit, like obviously in a perfect world, unlimited finances, we could have the most perfect, we'd be probably talking about like a city bus, I guess at that point, fluoroscopy table and a transport stretcher, but I mean, what does that future hold? Like, could that get to that point where you get that patient, you cannulate at the scene, you get them in the unit, can you start the transport, or would that be a program goal for the future?
So that's where it gets really complex because we have PSA area, like all the PSAs. And so if we come in and then we do the transport, then it affects the service area.
Right.
And so I truly don't envision that ever being a thing with our team because it will take away a transport from another agency. And therefore, like, it won't work out. Would it be nice? Absolutely. And if it were to come to that point where, hey, we have a mutual aid agreement, there's financial back-end clearance, things like that.
Sure.
All we have to do is drop the pins in. We have our chair, like we have the chair, the captain's chair that can go in there. So we could do a transport. With how big the truck is, honestly, I don't see it being an ever mean where it goes downtown Minneapolis.
Right.
But, in the future, it might be that we have a smaller ambulance and that is something that we can rendezvous with and then,
transfer the patient over into that and then move forward.
Yeah. So this is obviously very robust, and I feel like there's, about 50 different tangents that we could go off on so many of these things and probably, talk about each of them individually. But what still is so impressive to me is all of the resources that need to come together to make this happen. And so with that, in mind, like how many cannulations is your team seeing like on a monthly basis now, or on a yearly basis that you're doing? I know you said you reached your 500th mark, but I'm presuming the occurrence of this is increasing on a pretty regular basis. So what are you guys currently seeing for numbers, and what kind of outcomes are you having with it aside of the 30% that we talked about?
Right. Numbers are crazy, honestly. And like this last week the last 2 weeks has been insane. We've been doing at least one, if not two activations a day for a 24-hour period. I think the one 24-hour period, a 3-day period, we did 7 cannulations.
Wow.
I was just actually texting with our intensivist the other night, and she's like, I just don't even know what patient you're talking about because we've had so many.
We've done so many of them at this point.
And it's so true. But you can see and feel that as soon as we go out and do a ton of education, it relights. I mean, everyone knows this. If you don't continually re-educate, it falls by the wayside.
Out of sight, out of mind.
And every team knows that. It's no different. That's why we do quarter of the sims and things like that. So you can tell, like, when we go and do education, our number volume definitely goes through the roof. But I would say on average, we're screening about 30 to 40 a month.
That's crazy.
And so with that, we're probably cannulating about 20 a month. So last year we did, I think it was either 144 or 166, one of those two numbers, patients that were actively cannulated last year for VF or VT mobile.
Those are impressive numbers. And to see all of those resources coming together after all of these years of hard work, it's not just the hospital system, it's EMS, it's the communication centers, it's all of your PSAPs that are out there, it's your flight agencies, it's literally an entire community coming together to try to provide this resource. And I think that's something that's so impressive, and we'd love to see that collaboration, in more places than just up north in Minnesota.
Yeah. And I think that's the hard part about it, right? Is our team is an exhausting resource. And like, I don't mean that in a negative way, but like, you have to think, so one patient and all the resources that one patient does, and then we bring in 2, 3, sometimes we've done 4 ECMOs in a day. And so, that involves the cath lab on Saturdays. They're coming in. And so instead of spending, a couple hours doing a PCI, they go home, they get called back in, and then they come back and do their normal 40 the next week. We talk about the ICU staff, so the ECMO specialists, the nursing staff, it's just a constant revolving doors of bringing patients in, doing the resuscitation, landing the patient, bringing them down to CT, decannulating, transferring them out, the physician team, our clinician team. So really, we talk about this at a very high level, that if any one of our team members wouldn't perform, our outcomes wouldn't be what they are.
Right.
And, we really tell people who come and shadow our program, who want to start it, is like, if you don't have all this support, you will never have true good outcomes.
Right.
Because
it really does take a
anytime
village.
one fails, it's detrimental.
Right. Yeah, for sure.
And
it's so awesome to see some of that. And I feel like there are a lot of roadblocks that, there have been probably a few other places that have tried to go down similar routes, and they hit one roadblock or another. And to really see your entire community coming together to provide this kind of service, it's, hats off to all of you, each and every part of that puzzle.
Thank you.
You mentioned, the team can be exhausting. In that light of it, all the resources that are just available for it. So, I mean, like Mike said, just you guys are doing such incredible work up there and striving so hard to improve those outcomes for patients. And I think the numbers that you guys are putting out really speak for itself. So I think this was amazing to be able to talk about this. And I hope that, other communities and other places really take notice to see that it is possible. It does take a village, but if you have everybody's buy-in, we can really make a huge difference in getting people another chance. So I think it's amazing.
100%.
Thank you, Kevin, for coming and talking with us about this entire process. I can't tell you how impressed I am with, everything that goes into just saving one life, and the amount of resources and dedication and expertise and professionalism that your team does it with is just out of this world. So thank you very much. And please extend our thanks to everybody at your team to keep pushing forward. And I hope that this inspires a lot of other communities out there. And like I said, this is a very different podcast for us, as far as, maybe it's not solely focused on the air medical industry, but I think that there's a big air medical component to all of this, and how we can maybe take away some points of how we can get the patient to the right place at the right time with the right resources and streamline that process so that we're doing better by the patient. And so I think there's certainly a lot of takeaways for everybody, whether you're in air medical or not, from this discussion. And we really appreciate you coming on and sharing, all of this amazing data and the amazing things that you and your team are doing.
Yeah, thank you guys for having us and or having me. I'll extend it out to our team. But yeah, we love doing what we do, and without the community, we wouldn't be what we are. So, as a team, we do the brunt of it on the front line, but at the end of the day, it's the ICU, the cath lab who really bring the patient across the finish line. So without any one of them, we wouldn't be what we are.
We can definitely see the passion in talking with you about all of this. It's definitely something that's gets you up in the morning and probably is very fulfilling at the end of the day for you. So thank you again for coming out and having that discussion. If anybody's interested in getting in contact with you or has any other questions, is there a good way that they can do that?
Yeah, I'll send you over my email, but we're always open to, we do allow people to come up and shadow our program. We do have like some pamphlets and things on how to build an ECMO program in the community. And so, that's part of our team dynamic is like, it's not just us, like we're here for the better of the most.
Yeah.
And, if you're in London, we have people coming from London, or if we have people coming from Texas and all over the world to shadow our program, because why reinvent the wheel when you can just optimize it or
Right.
make it a little bit better for your part? And so absolutely, email, phone, whatever you have, open for
Awesome.
communication.
Well, thank you, Kevin, very much. I'm sure there's going to be lots of questions that are sparked from all of this, and we really appreciate you and your team being willing to share everything and affect not just Minnesota, but potentially the world with some of the processes that you're going through. So this has been a very enlightening discussion, and we can't thank you enough. Also want to thank our guests for tuning in. I hope you guys enjoyed this conversation and are hopefully taking this back to your agencies and talking about how you can streamline the process and hopefully have some better outcomes for your patients that may be in cardiac arrest and getting them to the appropriate centers. Also, thank you to our listeners for their continued support of the Vertical Helicast platform and the Valor Flight Crew podcast. And we will see you all next time. Thanks again, everyone.
Thank you.
Thank you.
Thanks for joining us for this episode of the Valor Flight Crew podcast. Don't forget to like and subscribe to hear more stories that promote the personnel and equipment behind the missions in public safety aviation. Lastly, stand by for a message from our sponsors.
Thank you to our sponsor, Precision Aviation Group. Mission-critical operators and fleet managers rely on Precision Aviation Group as a worldwide leading rotor and fixed-wing MRO provider. PAG provides tip-to-tail solutions in 4 MRO segments: avionics, components, engines, and manufacturing DER services. A single point of contact gives you access to over 150 million in inventory globally, 24/7. Just call 800-537-2778. Precision Aviation Group. Others sell parts. We sell support.
Thank you to our sponsor, Metro Aviation. Metro Aviation, the world's largest family-owned aeromedical operator, offers comprehensive aircraft services with 140-plus aircraft in over 25 states. The Completion Center installs medical and law enforcement kits and avionics, serving diverse aviation needs including offshore, utility, VIP, and corporate sectors.
Well, that's a wrap on this episode of the Valor Flight Crew podcast. A huge thank you to Kevin Rixmann for sharing his expertise on mobile ECMO and its role in revolutionizing emergency cardiac care. It's clear that innovation, teamwork, and rapid response are key to improving survival rates and pushing the boundaries of pre-hospital medicine. To say it takes a village is an understatement, but the University of Minnesota Medical Center, as well as their local HEMS and EMS agencies, remain committed to providing world-class care when minutes matter for out-of-hospital cardiac arrest patients. We hope this conversation left you with new insights and a deeper appreciation for the incredible work being done in the field. If you found this episode valuable, be sure to like, subscribe, and let us know your thoughts. We look forward to bringing you more amazing discussions promoting the personnel and life-saving equipment behind helicopter air ambulance services. Until next time, fly safe, take care of yourself and your team, and keep pushing the boundaries of cutting-edge patient care. Thanks for tuning in.